Hi everyone. Uh, Today we will start first online lecture about hematology. I hope everyone is fine and I hope we can pass this crisis because of the corona infection. We know online lecturing is an alternative to the classical one, but because of this situation we are obligated to give the lecture online. Every student have its my email. They can question me on my email or on my phone directly. We will start hematology today. First we will talk about hemopoiesis as the first part, as a starting point for the uh, lectures on pediatric hematology. Everyone knows that the site of hemopoiesis uh, have different stage according to the age of the fetus. Uh, First, in the fetal life, it started from the mesoblastic. After that, second stage start from the hepatic, and third from the myeloid. All hemopoietic cells are derived from pluripotent hemopoietic stem cell. When we say pluripotent hemopoietic cell, it is obvious that this as a stem cell which have pluripotent, have the tendency to produce any type of blood cell, including white BC, including red blood cell, including platelet count. So we should know that according to the age, the site of the production of the blood cells are different. First we start from the mesoblood, after then to the liver, after that it will change to the bone marrow. And according to this picture, it is obvious that from at which age, and the production of the RBC is done. The first, the erythrocyte production in the yolk sac, appearance of the blood cells will appear in the yolk sac as the first site for the RBC production. After that, migration of the blood cell to the liver, it will start from the production from the liver in the 4th month of pregnancy. The RBC production will start from the bone marrow, and the 5th month of pregnancy, leukocyte and platelet production also start from the bone marrow. In the 7th month of the pregnancy, erythrocyte production will start will be more specific to the bone marrow. So it is starting from the mesoderm in the yolk sac, going to the liver and going to the bone marrow. And we should know that the hemoglobin is differ according to the age of the child. In intra-embryonic life, the structure of the hemoglobin is different from the that which is present during the labor and differ from that present in the adult. And every doctor should know what are the types of this hemoglobin. And for that, you should know that the hemoglobin is composed of the heme and globin. The globin is the main structure that will differentiate and it will form different type of hemoglobin. Everyone should know that hemoglobin we have two types. First, we have alpha gene and beta globin chain. So hemoglobin structure is composed of the two two chain. One is called alpha, one is called beta. What do we mean by alpha? Alpha is related to the gene cluster. So any type of the chain which is produced from the gene which is present on the alpha gene cluster, it's called alpha type globin chain. Beta gene, it's another type which is present on the beta gene cluster. So this nomenclature come from the site of the gene which is responsible for the production of the chain of the globin. And according to this slide, you should know that in embryonic life, hemoglobin have three types. We have hemoglobin Gower 1, hemoglobin Gower 2, hemoglobin Portland. So when we say hemoglobin Gower 1, it means that the beta chain in this hemoglobin is composed of two chains. The alpha gene is 2 zeta and 2 epsilon. The beta chain is epsilon. So if you have a hemoglobin, the beta chain composed of zeta and epsilon, it's called hemoglobin Gower 2. while in hemoglobin Gower 1, sorry, hemoglobin Gower 2 composed of 2 alpha and 2 epsilon, while hemoglobin Portland is composed of 2 zeta chain and 2 gamma chain. So this nomenclature comes from the beta globin chain. While in fetal life, usually this type of the hemoglobin will be changed to hemoglobin F, which is composed of 2 alpha and 2 gamma. While in adult life, so after labor, the hemoglobin will start to be changed from the hemoglobin F, which is fetal hemoglobin, to the adult hemoglobin, which is composed of hemoglobin A and A2. And we know that hemoglobin A is composed of 2 alpha and 2 beta. The beta chain is different from hemoglobin, fetal hemoglobin, which is 2 gamma chain. And this is very important clinically because we should know that during the early neonatal life, hemoglobin F is present. And why is this hemoglobin F present? This is a protective mechanism. You should know that the fetus is competing with the mother or the maternal tissue for the hemoglobin. So if both the maternal and the fetal hemoglobin are the same, it is obvious that the first tissue which is in frontier with the lung and in frontier with the oxygen content is the maternal tissue. So if they have the same tendency to get oxygen, so the child, the fetus will get hypoxia because oxygen is going to the mother. It will take a lot of it and few remain for the fetus. So the affinity should be more for the neonate, for the fetal. So the fetal hemoglobin is different from the maternal hemoglobin in the way it is more powerful to attract oxygen and to bring oxygen from the maternal blood. That's why this difference is present. So it's a protective mechanism that gives the chance of the fetal tissue to get oxygen from the blood, which is in competition with the lung, because there are just two lungs working, which is belonging to the mother, and the two lungs of the neonate is not working. So this neonate should compete with the mother tissue for this oxygen in this way, because it's far away anatomically from the lung. So the fetus hemoglobin should be more powerful to retain oxygen. That's why the hemoglobin is different. So hemoglobin type in newborn and adult, usually in newborn there is presence of hemoglobin F, which is transitional period when the child, when the neonate coming to this life, it will be changed from hemoglobin F to hemoglobin. And this need few months. So if we, and one of the clinical importance that hemoglobin F is persist beyond and persist for early childhood, it's a sign of thalassemia, as we know, because in thalassemia hemoglobin F present because the hemoglobin which should be replaced with it will be not formed because of some defect. So presence of hemoglobin F in the early neonatal life, it's normal and it is not indicative of thalassemia. So we should not search for thalassemia by hemoglobin electrophoresis during the first few months of the life. And this lecture is showing us how is the beta and globin alpha chain is produced. We said alpha and beta chain is located to the locus. So only as this show that usually we should know that hemoglobin is a 64.4 tetramer consisting of two pair of globin polypeptide chain, one pair of alpha-like chain. We say alpha-like chain because it's come from the gene locus, which contains the gene for the alpha and also for other type of the chain. And also other is beta-like chain, which contains the locus for the beta and other chain like beta. So, and this group of genes which are different, which are responsible for production of the chain, same gene contain beta. So the beta-like chain, beta-like gene which produce beta-like chain peptide. The same in the alpha. So when we talk about cause of anemia, usually we should know the cause of anemia is different according to the socioeconomic of the country. We have a cause of anemia in countries with low or middle income, like in our country. We should know that there are nutritional causes. It's important cause for the anemia in this age group. We know production of an RBC. RBC is a complete cell that contains many substance, many micronutrients, many metals. So deficiency of one of the substrates will cause anemia, like deficiency of iron, deficiency of folic acid, deficiency of vitamin B12. While other cause of anemia may be due to a problem in the genetic, like genetic cause for hemoglobinopathy, thalassemia, hemoglobin variant, glucose 6-phosphate deficiency, all have genetic base, or maybe infectious, like in malaria, some infection will cause hemolysis. So when you talk about anemia, we should know that anemia is defined by a reduction in the red blood cell mass or blood hemoglobin concentration. So this is a definition of the anemia. Classification is according to the etiology. According to the etiology, we can classify anemia into decreased or impaired production. For example, what caused decreased production? Example, deficiency of a substrate for the hemoglobin or RBC, like iron deficiency, maybe depression of the bone marrow. So there will be decreased production when there is impairment of the factory, which is bone marrow in the neonate. So like in hypoplastic anemia may be caused by congenital, may be acquired. Congenital cause for hypoplastic anemia may be pure red cell anemia, which is just RBC defect production from the factory, which is genetically determined, and like in Fanconi anemia. In Fanconi anemia, other line also may be affected. There may be acquired cause for hypoplastic anemia, like radiation, like chemotherapy. The second one for depression of the bone marrow is by bone marrow replacement by abnormal cell, like in malignancy. Other causes for anemia according to the etiology, for example, first we said decreased production. Second, maybe blood loss. For example, in hemorrhage, it may be acute, it may be chronic. Always there may be production as well. There is no direct bleeding, but there is excessive RBC production. This will, when the RBC production is more than the power of the bone marrow to compensate for the distracted RBC, anemia, clinical anemia will be apparent. Morphological of this was classification due to etiology. We have another classification which is due to morphological classification. This is very important. So one of the approach to the child with anemia is according to the morphology. So we can classify RBC according to the morphology into 3 groups, and each group caused by different causes of different defect. So when we classify it to according to the morphology, this will be a good way to diagnose the defect at the last and to manage this case. For example, we have, according to the morphology, we can classify anemia into microcytic hypochromic, and these are RBC are smaller than the normal one, and there is pallor of the cell. So the cell is not contained enough hemoglobin, so the cell are hypochromic. The color is less than the normal. It may be macrocytic normochromic, it may be normocytic normochromic. And we know macrocytic, it means large size RBC, so the MCV is high, which is main corpuscular volume, like that. So in this main corpuscular volume is larger than the normal. This is the normal size. This is larger, this is smaller, which is microcytic anemia. And according to this, what's important when you have classification according to the morphology, after that we should subclassify this according to the reticulocyte count. Reticulocyte count, we know it's a precursor of the mature RBC. So when the bone marrow is functioning well, there is an increased production of the RBC to compensate for the loss. Reticulocyte count will be more produced, so the reticulocyte count will be higher. For example, in microcytic anemia, when there is low or inadequate reticulocyte count, like cause for iron deficiency, thalassemia triad, chronic disease, while high reticulocyte count with microcytic anemia, like in thalassemia syndrome. We should know that some disease, for example, thalassemia, is causing both of them. So in thalassemia triad, which is a thalassemia which have no fully blown clinical picture, it's a mild form. You can see low reticulocyte. While in the fully blown thalassemia, you can see high reticulocyte count. So in some disease, you may see two types, because one disease may cause macrocytic, and same disease in another person may cause macrocytic. So some causes may be shared between two groups. But when you find it's microcytic, it is high first in top of your thinking should go to thalassemia major. Same for other types of anemia. For example, normocytic anemia, like in high reticulocyte count, like example, antibody-mediated hemolysis, hypersplenism, while low reticulocyte, like in chronic disease. So it's the same. So every doctor should know the causes of this subcategory of anemia. So, and for the student, at least every one of you should know the first three causes for the common causes for this. So when you should know causes for microcytic anemia with low reticulocyte count, you should know the first three one. Same for the all you should at least you know the first three one, and if it is know you know more, it's better for. So anemia, when a child have anemia, there is some physiological adjustment to the anemia, including increased cardiac output. So we have a normal person. When you say live person, is different from another which is non-live, inert. It's different because live person can compensate, can change function, can change shape according to the environment, according to the insult. Same for the human being. So if a person have anemia, the person will try to compensate for the decreased amount of the red cell by doing some physiological change, like increased cardiac output. So if you have a person can cardiac output is, let's say, about 3 liter, but if the heart rate is 10 bit per 170 bit per minute, let's say. When this heart rate is increased, also the cardiac output is increased. So the aim of cardiac output is that the rate of flow of the red cell will be more, so the oxygen will be more available to the tissue with the lower concentration. Augmented oxygen extraction, shunting of blood toward the vital organ. It's important when the child have anemia. So priority to the vital organs, so the body will compensate and will redirect the blood flow from the muscle to the kidney to the heart to the brain. All these are vital organs. Concentration of 2,3-diphosphoglycerate increases with the RBC. Shift to the right of oxygen dissociation curve. We said to the shift to the right, you have shift to the left, you have shift to the right. In the shift to the right, the oxygen will be more easily delivered to the tissue. Higher level of erythropoietin will be increased. Why? Because this erythropoietin will enhance more production of the RBC to compensate for the decreased amount of the RBC in the body. Consequent increase in the red cell production by the bone marrow. In anemia, when you have a child with anemia, it's like any other disease in medicine. First, you should concentrate on the history. In some person, you can have a clue for the diagnosis of the real disease in the history. In another person, you may have a clue in the physical examination. In another person, you have a clue in the investigation. So it's like in medicine, you should start by good history. In some person, the good history will just will be enough to diagnose. In some person, history cannot give any clue, so you can detect a clue in physical examination. In other disease, both history and physical examination normal. By some investigation, you'll find the cause. So it's important. Like any other disease, you should have a good history, good examination, good investigation. In history, age and sex of the child is very important. For example, age like physiological anemia of prematurity. So if you have anemia in a premature child, you should know that the child is premature, the age is premature, so you expect anemia compared to the full-term baby. That's why age is important. Sex is very important because some diseases are X-linked disorder. For example, hemophilia. Usually you don't see it in the female, which is most of the condition you see it in the male. That's why you should ask about this. You should talk about severity of initiation of symptoms like lethargy, tachycardia, and pallor. You should ask about body compensatory ability. You should ask question about related to hemolytic episode. We know the threat of the hemolysis is what is anemia, jaundice, and red urine, hematuria. Prior RBC therapy or anemic episode, question about possible blood loss, other important question. You should know this and you should elaborate. So when you have a case, long case with anemia, you should concentrate. These are points very important. You should concentrate on the history. Examination, same like history, there are some important points you should concentrate, like in skin you should look for hyperpigmentation. Fanconi anemia, you should look for jaundice, as you said, hemolytic anemia, you should look for the ulcer, you should look for this hand, and you should check for spondyl hypoplasia, diapharyngeal thumb, because everyone is a clue for a specific cause for the anemia. You should look to the eye, to the facies, to the spleen. These are very important clue in the physical examination. We said some person you may detect a clue in the laboratory study. For example, initial laboratory testing should include hemoglobin. So any case with anemia, you should check the following. You should check hemoglobin, hematocrit, red cell indices, white blood cell count, and differential platelet count, reticulocyte count, and examination of the peripheral blood smear. Additional laboratory study is directed by the history and physical end result of this initial test. For example, you can do a genetic test. So if in a specific person, in some person you suspect, let's say one of the genetic disorder, you can send for the cytogenic analysis or molecular genetic analysis. This depends on the disease when you suspect a genetic problem. Or you can do blood collection and you can check RBC, platelet, and white blood cell, because if all are three affected, you think of whole bone marrow affection by the problem, like in malignancy, like in myelofibrosis. Just RBC, it means non cell line is affected, so your diagnosis, differential diagnosis, will be a narrower. One of the important things in pediatric age group is iron deficiency anemia. In iron deficiency anemia, it's one of the common problem in our country, and we see a lot of cases are presented to the doctors, to the pediatrician, because they have anemia. And when you check for the iron deficiency, there are some sign of iron deficiency. You investigate, you diagnose iron deficiency anemia. So it's one of the common problem. And everyone of you should know that the important point in the iron metabolism. For example, newborn contain about 0.5 gram of iron, while adult contain 5 gram of iron. So full-term infant require 0.5 milligram of iron daily, elemental iron daily. In the first half of infancy, the body depends on the iron reserve. After 6 months of age, this reserve depleted and iron has to be supplied. So usually if the mother is not iron deficient, you don't see iron deficiency anemia in the first 6 months. While if the mother has severe iron deficiency, so the main source for the iron stored in the neonate is from the maternal. So if the mother is highly iron deficient, so you can expect iron deficiency anemia in her baby in the first few months of life. That's why they advise the mother to take good iron. They are usually prescribing FeFol, which is iron folic acid, for the lady who are going to have the conception, even for every lady, because of the monthly loss of the blood through the menses. That's why they advise giving iron for the mother before the conception. Iron is transported in the plasma in ferric state, combined with transferrin, by which way iron can be delivered to the bone marrow and spleen and liver for storage for the erythropoiesis. Iron is absorbed in the duodenum in ferrous state, usually oxidized iron that apoferritin causing ferritin. So what's ferritin? Ferritin is the oxidized iron with another protein which is called apoferritin. Both of them will form ferritin. Ferritin is very important because it is indicative of the iron storage in the body. Usually in anemia, there is reduced ferric acid and increased apoferritin. The apoferritin is more, the ferritin is less, because there is no iron to combine with apoferritin to form ferritin. Usually iron is an essential nutrient. You should know that 75% of iron is bound in heme protein, hemoglobin, and myoglobin. 22% is bound in the storage protein, ferritin and hemosiderin. 3% bound in the critical enzyme system such as catalase. So the iron does not contain in the hemoglobin. They also have a lot of other sources that iron is one of the main con, uh, constituent, like in the enzyme. Most iron is recycled from the breakdown of the old red cells by macrophage. Heme dietary sources like fish, poultry, and meat are good sources for the meat, and they have higher bioavailability of iron than do non-heme vegetables. So what you mean by availability? So if 10 milligram of iron is ingested from the uh, from the heme containing food, same amount ingested in the non-heme, let's say 7 milligram will be absorbed from the heme sources, while just 5%, 5 milligram will be absorbed from the heme. So bioavailability of the heme sources is more like in fish, poultry than the vegetable. Same for the milk. So bioavailability of the iron in the breast milk is more than the buttermilk. So if you have breast milk and buttermilk, both of them contain 10 milligrams. The 7 milligram of the breast milk will be absorbed, while 4 milligram of the buttermilk will be absorbed. So bioavailability is much better. Ascorbic acid enhances the absorption of non-animal source of iron, whereas T brown foods rich in phosphate and phytate inhibit iron absorption. That's why taking a lot of tea, usually after eating a diet which contain heme, will decrease the iron available for the absorption. Iron deficiency anemia, you have a lot of etiology, a lot of causes. Most commonly, usually we know that it's common after the age of 6 months, when the store is depleted until age of the 24 months. Usually we have causes for the iron deficiency anemia include inadequate supply of the iron, like inadequate store of the iron at birth, for example, preterm delivery, twin, multiple births, extremely severe iron deficiency in the mother during pregnancy. You have fetal hemoglobin hemorrhage at or before delivery. Sometimes there is a hemorrhage from the fetus, or twin to twin hemorrhage. Inadequate intake of iron, usually are inadequate supply. You have impaired iron absorption. We know that iron is absorbed through the bowel, so celiac disease, chronic giardiasis, malabsorption that could affect the functional capacity of the bowel will cause impaired iron absorption, and net result will be iron deficiency anemia. You may have a normal iron absorption, but the demand is more. For example, if the person have the same iron absorption, 10 milligram of elemental iron per day, but it's a chronic loss, let's say from GIT or from another space. So this iron is enough for a normal person, while for a person with bleeding, daily bleeding, is not enough. That's why increased demand for iron, like in blood loss, failure to meet increased demand for growth in preterm baby and during adolescence. These are when the iron requirement is increased. Usually clinical feature of iron deficiency anemia include many symptoms: pallor, lethargy, irritability, anorexia, fatigue, pica. One of the common presentation is usually pallor, and the fatigability is a common symptom that usually the parents seek doctor for the iron deficiency anemia. There are a lot of signs, including same pallor. So the pallor is detected by the parent, it's called symptom. If detected by the doctor, it's called sign. Mild splenomegaly, usually it's not a good or common presentation. Fragile nil, tachypnea, atrophic glossitis, dysphagia is usually rare in children, more in adolescent. Laboratory investigation is very important. For example, hypochromic microcytic anemia with poikilocytosis, target cell decreased PCV is very important. You should know that there is decreased PCV, which indicate microcytic anemia, because the cell volume is low, so it is microcytic. Decreased hemoglobin concentration, slight reduction of RBC count, decreased MCV, main corpuscular volume, size of the so what's MCV, what's PCV? PCV is a percentage of the RBC mass or cellular mass compared to the plasma, while MCV is a size of the corpuscle of every RBC. So this is microcytic, so the MCV will be low. Decreased MCRC, what indicate main corpuscular hemoglobin concentration and main corpuscular hemoglobin concentration. This is when we say main corpuscular hemoglobin concentration, it means the concentration of the hemoglobin in one RBC. While main corpuscular hemoglobin, it means concentration of hemoglobin in a volume of the RBC. Let's say 1 ml. So both are indicative of the decreased hemoglobin. Normal YBC, platelet or reticulocyte, means there is iron deficiency, is not affecting the other line of the blood production from the bone marrow. Decrease S ferritin to less than 10 microgram is very important. Ferritin, decrease serum iron, increase total iron binding capacity, transferrin. So there is no a normal amount of the iron to be combined to transferrin, so the iron is less, so the transferrin is more free. They are more have the power to combine with the iron, so iron binding capacity will be more. Bone marrow examination is rarely required when performed. It shows erythroid hyperplasia, usually not required, but when you think of other diseases, you can do bone marrow. So we can compare this to blood smear. We show this is a normocytic anemia. There are a normal lymphocyte, there are no normal lymphocyte there. The RBC, usually they are pale. And usually the diameter of the normal red cell should approximate that of the nucleus of the small lymphocyte. So if you see the lymphocyte, the diameter of this RBC should be equal to the nucleus or near to the size of the nucleus of the lymphocyte. So what happened there? There will be central pallor, red arrow. You see the central pallor here. So if you see to the normal, the pallor is not so much obvious like in a hypochromic microcytic anemia. So if you see to the central pallor, it is occupying a larger space here compared to a normal person. So in a normal person, there is a central pallor, but it is increased in the hypochromic anemia. So what you see in the hypochromic microcytic anemia, there will be pale small red cell with just a scant rim of pink hemoglobin. So here there is a central pallor, but the surrounding hemoglobin is of a good amount, while here it's of a little amount, as much less than the normal. Differential diagnosis of iron deficiency anemia include thalassemia minor, anemia of chronic infection, lead poisoning, sideroblastic anemia. We will discuss every one later. So what's important? These are important parameters that can differentiate any iron deficiency anemia, especially from the thalassemia. So in serum iron, usually in iron deficiency anemia is low, while in thalassemia usually it is high. You have same for hemoglobin electrophoresis, which is abnormal in the thalassemia. They are showing abnormal beta chain. Usually bone marrow iron is absent in iron deficiency, while there is overload in thalassemia. Saturation, iron saturation is less here, while it's normal or increased there. So treatment of the iron deficiency anemia is important. Usually the regular response of iron deficiency anemia to adequate amount of iron is critical diagnostic and therapeutic feature. So when you have a case of iron deficiency anemia, when you supply iron, there will be a good response. This can be used for diagnostic tests. So if you are not sure, you don't have a good facility, you can give a trial of iron. If there is good response, it indicates there is iron deficiency anemia. Iron is available in many forms, including drop, syrup, tablet, and injection. Usually we give 6 mg per kg per day. Some person advise vitamin C because it has absorption. Oral therapy usually continue for 4 to 6 weeks after hemoglobin value is normal. Parenteral iron, you can give parenteral iron when there is poor iron absorption, when it's difficult to compensate continuous iron loss, intolerance of iron, oral iron, non-compliance of giving or taking iron. This is a calculation to how much iron you are given. Depend on the blood volume, average hemoglobin, actual hemoglobin, and how much iron is given. In iron deficiency anemia, response to the iron therapy is very important. Usually in the second 12 hours, there is replacement of the intracellular iron enzyme, subjective improvement, decreased irritability, increased appetite. In 36 to 48 hour initial bone marrow response, there will be erythroid hyperplasia. In 48 to 72 hour reticulocytosis peaking at 5 to 7 days. In 4 to 30 days, increased hemoglobin level. In 1 to 3 months, there will be repletion of the store. So after fully recovery of the symptom, you continue iron supplementation to replenish, to restore the iron store in the body. Iron deficiency anemia, best way for prevention is breastfeeding, because we say bioavailability of the iron in the breast milk is better, uh, and you can, if you are giving bottle fill, you can adding iron fortified cereal after 4 to 6 months of age is very important. Infants who are not breastfed should only receive iron fortified formula. Cause for failure to respond to oral iron treatment is wrong diagnosis, non-compliant, persistent hemorrhage, impaired bone marrow response as in presence of chronic infection, impaired absorption, unknown causes. These are cause for failure of the treatment for the iron deficiency anemia. Another disease which is rare but it's important theoretically, you should know, it's called sideroblastic anemia. Usually, definition of sideroblastic anemia is result from the acquired and hereditary disorder of the heme synthesis. So there is a defect in the production of the heme. Usually there are picture of dimorphic population of erythrocytes. This is very important whenever you see a clue in the question talking about dimorphic population. There is, you see a blood film, there is dimorphic population. So in the blood film you see many cells are small, other cells are large, so it's like from two population. Usually differential diagnosis include blood transfusion and sideroblastic anemia. These are very important. As we know, we can look to the parameter RDW is very important, red cell distribution with it, which mean what? So if RDW distribution is high or is high, what indicate? Mean some cells are small, some cells are large. So the distance between these are wide, which means there is a lot of cells are small, a lot of are large. So this is very important. And how much is small, how much is small? Usually it's difficult to detect by RDW. When at this time you look to the curve which is present on the paper of the CBC, which is called RBC histogram. In the RBC histogram, the width of the RBC curve indicative of RDW. In this, you can know how much of the population is in the small side, how much is in the large side. So to better know how is the population, how much are small, how much is large, you should look to the histogram in the CBC. We talk about this in clinical, you know everyone what's as a histogram. Impaired heme synthesis leads to retention of the iron within the mitochondria. There will be aggregate of the iron in mitochondria that have a perinuclear distribution. This the name is called KIM, which is sideroblast. Usually hepatosplenomegaly is present. Sideroblastic anemia treatment is blood transfusion, iron chelating agent. Another important subject in the pediatric hematology is megaloblastic anemia. What mean by megaloblastic anemia? It's a rare form of anemia, but it is usually infrequently we see it in the pediatric age group. When we send a CBC, we see a large cell with anemia, large RBC cell with anemia, high MCV. Usually it's obvious that major cause for this is vitamin B12 or folic acid deficiency. Causes include children fed by goat's milk are potential risk of folic acid. So if the child taking goat milk, usually they are liable for folic acid deficiency. You have a lot of drugs that cause folic deficiency, phenytoin, folic acid antagonist, infestation by fish tapeworm, which cause vitamin B12 deficiency. Both statutory and chronic liver disease. Later in the next lecture, we talk about both megaloblastic anemia and sideroblastic anemia. In megaloblastic anemia, it's characterized by the presence of macrocyte. Hypersegmented neutrophil is very important. So when you look to a blood film. If you see hypersegmented neutrophil, it is very important sign, which means the neutrophils nucleus are hypersegmented. It is more than the 3 segments. These are very important, a sign for the megaloblastic anemia, predominant of megaloblast. Serum, you can check serum B12 folic acid. Treatment is by intramuscular B12 folic acid. Dose of folic usually more than 0.1 milligram can correct the anemia of vitamin B12 deficiency, but may aggravate any associated neurological abnormality. So it is better to not give folic acid before you are sure it is not vitamin B12.